Good morning, everybody. It's Jo Root here from CHF, and with me I have Rebecca Randall. Thank you for joining us to talk about private health insurance and review of pharmacy. Two key policy areas that we did cover in a superficial cover of in the March webinar, but now we're going to go into some more detail because the agenda has moved on a bit. Before we start, I'd like to acknowledge the traditional owners of the lands on which we're all meeting today and pay my respects to their elders past, present and future, and to any Aboriginal and Torres Strait Islander people who might be participating in this webinar. The webinar is going to be in two parts. Rebecca's going to talk you through private health insurance, and we'll take some questions on what she has to say at the end of her presentation, and then we'll move on to talk about the review of pharmacy. And you can type your questions in. Those of you who've done this before know how to do it, and we'll try to get to as many questions as possible, and those that we can't answer that we think are key, we'll post answers up on the website when we put the presentation up. So over to Rebecca.
Hi everyone. As many of you will know, private health insurance has been a key area of focus for CHF over the last year. And so today I'm going to take you through a lot of our broad thinking on private health insurance with specific reference to a current Senate inquiry into private health insurance. I will be talking to the slides a little bit, but there is more content on the slides than I will necessarily be covering. And I would ask any thoughts, views, questions. We are really eager to hear them. This is a major submission for us. And it is one that is quite complex. And so if you've got views and opinions from that wonderful consumer angle on any of these, my email will be at the rest of the at the end of the slides, or you can type comments or questions in the box and I'll collate them afterwards. So broadly, the role of private health insurance in Australia is one that CHF is supportive of. We think that it fulfills those three key areas. It makes private treatment affordable, takes pressure off the public system, and it gives consumers choice. The government subsidises the industry to support that role to the tune of about $6 billion of taxpayers' money every year. We and a lot of the rest of the sector have a lot of growing concerns about the affordability and value and decreasing numbers having insurance. CHF hasn't taken a solid position on whether or not people should have private health insurance. We think the existence of it is key and important to the maintenance of the Australian health system. We're supportive of the two-tier health system. However, we have concerns about the current model and how it works with particular reference to that government subsidy. We feel that anything that the government is subsidising to the tune of $6 billion needs to be providing both value to the consumers who have it and to the taxpayer as a whole. So currently where we're at is there is a Senate inquiry into the value and affordability of private health insurance and out-of-pocket medical costs. As you can see the key slides on the key dates on the slide. The submissions close the 28th of July. There was a public hearing which commenced last week. I went as a witness on behalf of CHF, and if you are interested in this area, I would commend the transcripts to you. The terms of reference are incredibly broad ranging. You can see them at the link below. I would encourage you to go to that. But broadly, the ones that we are particularly interested in that we'll be covering in this webinar is the first one, private and public hospital costs and the interaction between private and public hospital systems, including private patients in public hospitals and any impact on waiting lists. Private health insurance product design, including product exclusions and benefit levels, including rebate consistency and public disclosure requirements. That particular one has been in the media quite a bit as gold, silver and bronze, which you may be familiar with. Then the take-up rates of private health insurance, including as they relate to the Medicare levy surcharge and the lifetime health cover loading, which we and others will refer to as the government subsidies and the way the government interacts with it. And lastly, the current government incentives for private health. So the main issues for us in private health insurance are the question of value and affordability. So the value proposition is really, is the current private health insurance system delivering value for both the people who have it and the Australian taxpayers who subsidise it through their government? through their income tax. We're also interested in ways that we can improve the understanding of coverage and benefits. The lack of understanding and the high costs of private health insurance are one of the most commonly raised issues with CHF. Private patients in public hospitals, government intervention, and the out-of-pocket expenses. So to go to that question of value, for policyholders, the idea of value is a combination of both price and benefits. So how much you're paying per year, and then what benefits you're getting out of it. The affordability of premiums and the extent of out-of-pocket costs when consumers are both buying and renewing. The level of rebates and cover for specific conditions or services. And for taxpayers, the key benefit is that it is supposed to take pressure off the public system, but we and a bunch of others question the extent to which that happens. So what value means really depends on three different things. If you've got private health insurance, how much income tax you pay, and whether or not you use the hospital system. To go to the first issue, private patients in public hospitals. CHF strongly advocates for the retention of the right to choose the doctor. If you use private health insurance in a public hospital, you maintain your right to choose your doctor instead of just the one you were assigned to do. Some of the questions that we would like to address is, does it allow people to jump the queue? Is informed financial consent occurring when people agree to go private? Are they just being asked at the admissions desk, do you want to go private? And do they know what it means? Is sufficient information being allowed? Should private health insurance products that only cover hospital treatment be allowed? And if we were to recommend that they be disallowed, which we're not currently thinking of recommending, what happens to rural and regional consumers who are otherwise incentivized to have private health insurance, but may not be able to use a private hospital? And then why do people opt for treatment in public hospital if they have private health insurance? Different states and different hospitals offer a different range of benefits, and that's completely up to them as to what happens. We are definitely interested in your thoughts on those key areas above. Now to product design. As you may have seen if you're following the media around this, Susan Lee, the former health minister, proposed 3 new tiers of private health insurance: gold, silver, and bronze. Current discussions, and I should have stated this earlier, sorry, current discussions focus really just around hospital cover. Extras or general cover are another aspect of private health insurance, and that is really, really important. You know, it's one of the main reasons that people take out private health insurance cover, but the current reforms are focusing on hospital cover, as that is simply where most of the money is. So the reasons to move to this include simplification, easier to compare policies when buying if you're only looking at 3 tiers, as opposed to the wide multitude of other tiers and products that currently exist. It's harder to compare them. And then the idea of more certainty over what's included when you're using. The issues to look at, which we are keen to get your views on in terms of how this tier system could work, is who and how get to determine which each of the tiers have. At the moment, there is a product called the CHIP, the Complying Health Insurance product, which is the lowest minimum that insurers are allowed to provide products for that get access to government incentives. CHF takes the position that the current CHIP is really too low. The products that still count towards the CHIP are really exclusionary based. There's a lot of different exclusions in them. And we have found, and others have also commentated, that these products often have so many exclusions as to be useless, and consumers aren't aware of the exclusions until they need to use them. What restrictions or excesses should be allowed to apply? Currently, there is a cap on the amount of excess that can be applied to private health insurance products. That is $500 per person and $1,000 per family product. We're keen to get your views on whether or not that should increase. We do take the view that the higher you increase in excess, the less people are likely to use that product when they need to, because they do have considerable out-of-pockets, in addition to the other out-of-pockets that also occur. But then also, what's the impact on premiums of any change that might occur? And then finally, what else needs to happen if we do move to a 3-tier system, or if we make changes to the current products that are allowed? We would argue that we definitely need improved information provision, including what information and how it's given. And finally, if we're implementing wholesale change, how do we make it happen? Does the current standard information sheet arrangement, is that sufficient? Do we need to revamp that? What information and when do people need it? I'll now move on to the next issue, which is government incentives to increase coverage. As I mentioned at the start, the federal government spends $6 billion per year on the private health insurance industry. Our current position is not to seek substantial changes on private health insurance. The current incentives are around the tax rebate. So the tax rebate is means tested. It's a sliding scale with lower rates for higher incomes. It addresses the affordability of private health insurance for individuals, but what is not clear at the moment is whether or not that assists with the other objectives of primarily reducing pressure on the public hospital system. There's the Medicare levy surcharge. So currently, if you have a high income and you have private health insurance, you are exempt from the Medicare levy surcharge, which is in addition to the standard Medicare levy. It encourages the uptake of lower value private health insurance to avoid the Medicare levy surcharge. This is a key area of concern for CHF, as we are worried that consumers are taking out private health insurance purely as a tax avoidance product, not a health product. We strongly take the view that health insurance should be a health product, not something that you can use to just avoid tax. And the last issue is lifetime health cover. It's probably the least well understood of these. Broadly, it's the stick that means that if you don't have private health insurance when you are 30, for every year that you don't take out private health insurance above your 31st birthday, you pay an extra 2% on your premiums. This stick worked incredibly well when it was first introduced, but we are now seeing the impacts declining. So one of the things that we are contemplating is that we need to rethink on the age or how long it stays, issues like that. So the question for us with these are, do each of these incentives and sticks and incentives deliver on the objectives? We'd really value your thoughts on that. So the final issue I'll be talking about with private health insurance is out-of-pocket costs. So in addition to excesses and co-payments, which insurers can and do apply, when you go into hospital, or this also does apply for extras as well, you often face considerable out-of-pocket costs. It's not just that. You have private health insurance, so automatically any admission that you use a private health insurance for, you are completely covered for. The reasons that out-of-pocket costs occur are really varied. They have to do with largely the multitude of players in any hospital admission. So just to give you an example, for example, with a hip replacement, you've got your surgeon, you've got your assistant surgeon at times, you've got your anaesthetist, you've got the hospital admission costs, and look, that can just be the start. There may be others. And each of these providers can and do charge differing amounts. Your private health insurer will have a contract typically with the hospital to say that you may have no gaps. But these agreements, contracts as they're known, vary incredibly between both different hospitals and different insurers. They are negotiated on a per insurer and per hospital basis. And it is an area where there is a great lack of transparency around these. And one of the things that we are concerned that this leads to bill shock. Often because of the multitude of players in this space, even with the best of intentions, these costs cannot be directly estimated before a procedure. And so even if you thought you were going to go in, and even if you did all the legwork, and that is a considerable amount of legwork, before you may still end up with out-of-pocket costs. And this is a reason that we find people don't use their private health insurance. There are some regulations around informed financial consent, and that all these providers and your insurer do need to the best of their ability, inform you of these. From your experience, are these enough? And then we come into that final idea of the role of hospital provider insurer contracts. We're after some ideas of what we could suggest to address these. Things that we are contemplating is whether or not doctors should have to publish their fees, whether creating a single quote or bill per procedure is likely to help. Currently, each of the players that I outlined are likely to give a consumer individual quotes and bills per procedure, which creates extra confusion at a time of stress. And then finally, to go back to that broader issue of product design, to reduce exclusions and restrictions in policies. Arguably, the less restrictions or exclusions you have from a policy, if you know that if you think you've got psychiatric cover, you are completely covered for psychiatric cover, that should reduce some of this. I'll go on to questions now. Okay, so look, so far we're not getting any questions. So I'll hand over to Joe, who is doing pharmacy, and then we do have question time at the end. Feel free to also chime in with private health insurance questions in addition to pharmacy if you have any, or please get in contact via email. And I would just like to thank the 3 consumers who have already given us feedback. We really appreciate your feedback, and it's been instrumental in helping our submission already. So over to Joe.
Well, thanks, Rebecca. Some of the things you might want to think about private health insurance, we'd be really interested if you have any personal stories about being asked to go private in public hospitals, who asked you, what your feelings were about being asked. There's been some questions about people being coerced into going private. So if you've got any of those stories that we can put into our submission, it always helps to have some real examples. And similarly with the out-of-pocket expenses, if you found that, you know, having been quoted out of pockets, you've decided not to go ahead with private health insurance, we'd really appreciate hearing from you, because I think that, you know, those actual examples always appeal to senators, if no one else, and they do make the point that sometimes the overarching statistics don't tell us. Moving on to the pharmacy review, this was the report was released on the 22nd of June. This has been a long-awaited report. We had been hoping to see it before this. It got held up through various processes. It's available on the link on the screen, and if you go and see the slides online, you'll be able to find it there. The review panel has had meetings with key stakeholders, including CHF, so we've had a chance to talk through with the review panel to get them to explain some of their thinking behind the options. They are options, not recommendations. I think it's important to remember that this is a report to government, and it'll go to government in mid-September. The government can then choose how to respond to the final recommendations that come from the review panel. Submissions close the 23rd of July, and we again would welcome any comments, and I've had a few, and thank you to those who've already sent us in some comments. Going to some of the options for reform now. Overall, we were quite happy with the direction of the options. I must admit we were a bit surprised. Stephen King, who is the chair of the review panel, had always been seen as somebody who was keen on deregulation and has a reputation for wanting to open things up for competition, and has actually suggested some additional regulation in this field, which we'll see whether that happens. But overall, I think the direction of the options would certainly help address many of the issues raised by consumers with us through the consultations we did, and more generally. We think the options will improve consumer experience if they were implemented. They also look to increase transparency and accountability for government expenditure in this area. And it is worth remembering that the Community Pharmacy Agreement is worth $18.5 billion over 5 years. It's not an insignificant amount of government and taxpayer funding, and I think taxpayers are entitled to see value for money and entitled to see where the money goes, and that's always been one of CHF's basic principles. What we'll be doing is in this discussion, I'll be presenting our preliminary response to some of the options, and we're looking actually for your input to finalise our positions. There's some that we are not entirely clear about which way to go and which way consumers would like us to go, so we are interested. I'm concentrating on those where they may be contentious or where we're not entirely certain of the response. And I think the first one of those is pricing. And this is an interesting one that since I've started this process, I've had some communications with a consumer who has highlighted the issues. One of the issues is, which many people don't know, is that a medicine, the top price, the maximum you can pay for a medicine is the co-payment that applies to you. So either the general co-payment or the concessional co-payment. Below, if the medicine is below that, a pharmacist can charge you whatever they like, providing it doesn't come to more than the co-payment. So people find that they can be charged different prices in different pharmacies for the same medication, and this can vary enormously. We hear people saying it's as much as $15 to $20 different for the same medication, depending on where you go and where you are. And we certainly, the feedback we've had is that people in rural and remote areas are tending to pay higher prices for medications than people who live in metropolitan areas and urban areas where there is some competition because there's another pharmacy in the shopping centre or just down the road. So this was obviously brought to the panel's attention, and they've made a decision that their option is to set the price for a PBS medication and to set it at either the relevant co-payment or the dispensed price for that medicine. And that's option 2.1. So there would be no discounting. So your pharmacist couldn't charge you less than the co-payment or the dispensed price, and couldn't charge you more than in the case of the dispensed price. There would be no additional fees allowed. Currently, there's things called an additional allowable fee, and a fee for putting it on the safety net, and a fee for this and a fee for that, which pharmacies are allowed to charge you. That none of that would be allowed. The dispensing fee for the pharmacist would be built into the dispensed price, and that would be the price you pay. Everybody who needed the same medicine would pay the same price effectively, and that seems pretty straightforward. We support the idea of a maximum price and it being either the co-payment or the dispensed price for that medicine. We think that people, the dispensed price is a fair price. If the dispensed price, if you go and have a look, might be $16, then that's all anybody should be asked to pay. What we're not so sure about is the prohibition on discounting. We know a lot of people access discounted medications through discounting pharmacies such as Chemist Warehouse. Different pharmacies have chosen to discount medicines as a way of offering value to their customers. So what it would mean if there was no discounting is that many people would now be paying more for their medicines than they are currently, because many are paying, maybe paying below the dispensed price. And we see that from information provided to us. So we're not sure what to say about this one. What we're suggesting is that much of the rationale is to help people in rural and remote areas who do not have the benefits of competition. We think there are other ways to assist them, additional payments, additional support for pharmacies in those. I think generally the CPA model of almost a one-size-fits-all, so the same rules and pricing and everything applies to the pharmacy regardless of where they are, with some additional payments for remote ones sometimes. I think we need to get a bit smarter about how we address rural and remote inequities without penalising consumers in metropolitan areas. This is a difficult one. We're not sure which way to go, so I would really welcome some feedback on that one. Sitting alongside that, the review panel has also put up as an option the abolition of the $1 discount on co-payments. We know only 30% of people get that discount, so it's quite inequitable. CHF supported the introduction of the $1 discount on the co-payment as part of 6 CPA because we thought it did offer some competition. People could maybe shop around if they had the capacity and found a pharmacy who offered it. But again, if you don't have another pharmacy in town, or you have 2 pharmacies in town, but they neither of them choose to do it, then you haven't benefited. The concern we have about the abolition of the $1 discount is that it would have a very negative, the biggest negative impact, as we've put on the slide, is the impact on concessional payments who don't reach the patients who don't reach the safety net. So if you're getting the $1 discount and then suddenly you don't get it anymore, then you're going to be paying more for your medicine. And people budget, and CHF has had a long-standing issue with opposing measures that increase out-of-pocket costs. So this one, we're having another think about what we can say in response to the idea to abolish. And again, I'd appreciate your thoughts. The other consumer experience part of the report, I think we are basically supporting all of the recommendations. Draw to your attention the development of a pharmacy atlas, a great idea to have something online or a tool that people can find out where's your nearest pharmacy, what services it offers, what hours it opens, and that's particularly important because we know access to extended hours pharmacy, people want to know where they are, want to know how they can find them. It, however, needs to be properly resourced to stay up to date. And we think the choice of the host is critical to consumer access. So where would you put it? So I'd be interested in views. We have the provisional view that perhaps the Pharmacy Guild website or the Pharmacy Guild is not the appropriate place to host it, because there are pharmacies that are not part of the Guild who may not want to list there. But where would you go? If you were thinking of looking for this, what are the places that you might want to find it, or how would you set about finding it? I think is really what we're wanting to know. The consumer medicine of information, and this is an issue that's a running problem, I think. The review commented of the fact that people often don't get their consumer medicine information or their CMI at the time of getting their prescription, and we know this is a problem. CHF is part of a working group run by Medicines Australia to have a look at what information is in the CMI and how we can get the CMI out to consumers in a way that will help them find it and keep it and use it. And the late Sally Crossing was instrumental in getting that working group together, because Sally was strongly of the view that we needed to improve this, that since we moved away from having medicine information in packets, in the medicine packet, people weren't getting it. Some pharmacists are not offering it. It's still, the way it's written is not all that helpful to consumers. A lot of them are online now. Do people know where to get them? Is at 3 o'clock in the morning when you're having a side effect, is it helpful to have to go online to find out whether that's a normal side effect or not? Or would it be better to have some printed material? So there is a working group going on that. We think that is important. We think it's important that pharmacists do adhere to the PSA, the Pharmaceutical Society of Australia guideline about when to give CMI. People should always be offered it when they move on to a new medication. They shouldn't have to ask for it in those circumstances. It should be offered. Of course, they don't have to take it, and if they do take it, we can't make them read it, but at least we can give it to them or offer it to them. We also think that doctors, as the prescribers, have a bigger role to play in getting consumer medicine information out to their patients. Whilst we think pharmacists need to do a better job overall on this, we do think doctors have a role to play in discussing with people what their medicine is for, the benefits of that medicine, and then some of the side effects. And then if you hear it also from a pharmacist, people have had the information twice. And we think that might help compliance, might help people take their medicine properly. And what we added here is that the review suggests that pharmacy and pharmaceutical companies should get together and redesign the CMI. Well, we're saying actually we think consumers should be part of that. We're a bit unfortunate that we got missed off there. So we will be saying that on 2.6 we should be part of it. The other one about electronic prescriptions, we strongly support the proposal to ensure that consumers have the choice on which pharmacy their electronic prescription goes to, so that their doctor can't decide where it goes, and it lets you say where your script will go, which pharmacy you want to use, and you may not want to use the closest one or the one you normally use, depending on the nature of the script. And it's yours. It's a consumer script, it's your script, you should have the say about where it goes. We think that's critically important, and we support the proposal. And the other one, which I know is always different and is different in different jurisdictions, so here I'd be interested to hear comments, is the medicines on discharge from hospital. Different state governments, state health systems do this differently. But what the proposal is saying, that everybody who gets discharged from hospital with a medicine should have a sufficient supply of that medicine to last them till they can get to a community pharmacist or a pharmacy, or get their script filled, however they do that. And they're suggesting that there should be a discharge pack, and there should be agreement about how much that is. And this becomes particularly important for people who live in rural and remote areas, and has been raised particularly for Aboriginal and Torres Strait Islander people who live on land and live in remote communities, who might leave hospital, have several days travel to get where they're going, and they need enough medicine to not just tide them over, but enough to give them some time to be able to access the medicine again. So this is one that if somebody needs a medicine on discharge, we should make sure they have enough to last them through. And quite how much that is might depend on the medication and the individual and where they're going to, but there certainly needs to be some more work on that. The next slide looks at community pharmacy services. So this is the King review. The review has looked at a minimum set of standards for pharmacy, and what can you expect from your dispensing pharmacy, from your PBS dispensing pharmacy? What is the minimum? And this relates back to the work in the Atlas. So the Atlas would contain this information, but hopefully most pharmacies who are receiving funding from the taxpayer through the 6 CPA, we would support this so consumers know what to expect, what it's reasonable to expect. Many pharmacies will go way above the minimum set, and we know that, and there are some great pharmacies out there and people are very happy with the services, so we're not saying they all drop those additional services, but we're saying what is the minimum set of services that you should have. And this is particularly important given that there is limited competition through the location and ownership rules. So we need to make sure that where you have only one or two pharmacies, that you're not disadvantaged in terms of lower levels of service than might be expected. So we think that's an important one. Complementary medicines is a tricky one for consumer groups and consumers. This is in options 3.2 and 3.3. We support the proposal to display complementary medicines in a separate section and away from other over-the-counter medicines. We support the proposal that they shouldn't be put behind the counter to reduce confusion. With other medicines, you know, there are S2s which you can access, and then there are other over-the-counter medicines that are held behind the counter because you can only access them if a pharmacist has said that you should have them. And we don't want complementary medicines put in that part of the process. We also think there should be better information at the point of display and the point of sale about the limitations in evidence on efficacy of complementary medicines. There is a process underway through the Medicines and Medical Device Reform that TGA is doing to look at the whole issue about what complementary medicines manufacturers can say about their medicines and what they can't, what they can claim. So that reform process will run separately to this, but we think people need to go for this. The King report has recommended that pharmacies be prohibited from selling homeopathic products. CHF is not clear on what its position on this is. While we agree with the NHMRC review, which shows us that there's little evidence of benefits from homeopathic products, they are a legal product. And so to tell a pharmacy what they can and can't sell is a bit tricky because, you know, they're allowed to sell all kinds of retail products. They're allowed to sell other complementary medicines. So we're not sure about this one, and I would welcome any views that people have about what our position is on that. We would certainly say with homeopathic products there should be large disclaimers near the products about the lack of evidence of efficacy, and pharmacy assistants and pharmacists should be clear about what they can and can't say about what these products can do. I think this recommendation comes out of the idea that some people choose homeopathic products and then don't go and see a doctor or get a different another medication, a more orthodox medication, and so their condition can deteriorate, and so there's a risk to the consumer. But I think this one is a very tricky one that we just need to think about what we're going to be saying. Remuneration for services, for other services. We're not going to make a comment about what the dispensing fee should be. I think that's between doing the sums and working out what's a reasonable payment for pharmacists to be paid to dispense medications. We would like to address 4.6, which is remuneration for other services. And the review wants to move pharmacists to the same ground as other primary health providers by saying same government payment should be applied to primary health services regardless of who is the service provider. This would open up pharmacies to having access and pharmacists to having access to NPS billing and charging for services, because that's how many other primary health services are funded. In principle, we would support that. We are concerned that there already seems to be a bit of a war going on between pharmacists and GPs about who does what best, you know. Every time you go onto Twitter, if you're a Twitter person, you can see this debate being run out in social media. You can see statements from both sides about who should be doing what. Our view on that is we want them to collaborate, not compete. We want them to work together. I'm sure there's enough to go around, and people have indicated to us when we did our survey on pharmacy that they want their doctors and their pharmacists to talk. And so that would be our basic position. We are concerned that moving to this billing for pharmacy could lead to an increase in out-of-pocket expenses for consumers if pharmacists choose not to bulk bill and charge different rates. And currently, you know, most of the services that are funded through the 6 CPA, like home medication reviews, people don't pay anything for at all. So could they now be paying for something that previously they hadn't been paying for? So these are some of the issues that we will put in our response to King, to the review, to see and to firm up our position. I've already touched on the location rules. CHF has a long-standing opposition to the continuation of the location and ownership rules for community pharmacy. The review did have some options for changing this, but is not pursuing them because both the government and the opposition have indicated that they don't want to go there. So it doesn't seem much point in pursuing this. But I think for the record, we certainly would maintain our opposition to those. We think they need to be reformed if they stay. We think there is scope for them being reformed, and I think having a clear statement of why we have location rules, what policy objective it's supposed to be achieving, and then seeing whether that outcome is achieved is a minimum that should happen if they're going to stay in place. So we would support option 5.4. I've already touched on opening hours and access. We were a bit disappointed with the response in the report about extended hours or possibility of 24/7 pharmacy services. They have suggested a 24-hour pharmacy hotline. We've thought whether that could be with Health Direct, NPS Medicines Line. Where would that be? Again, I'd be interested to know what your thoughts are about where you would get it, where you would go to find that. But it still doesn't raise the issue of you won't actually get the product. You'll get some advice, but it won't get you the medicine that you might need. So we think that that's one that needs some more work, and we'd be going back and suggesting. We know that the Victorian government is running a trial of extended hours pharmacy at the moment, and we'd be interested to have a look at where that trial has got to, and I think they're just about to expand it. So we'll be having a look at that, and if anybody online knows anything about that trial, please pass it on to me. I'd be really interested. And as I've already said, we believe there should be increased transparency of funding. It should be clear where the money's going, what it's going on, without disclosing the business, the commercial in confidence part of community pharmacy. And we need to accept and acknowledge that they are businesses. We don't want them to have to reveal everything about their business, but about the government funded part of their business, I don't think it's unreasonable. That brings us on to the community pharmacy agreements, and the review had quite a lot to say about the future of community pharmacy agreements and what should and shouldn't happen. They make a set of recommendations which are not mutually exclusive. Actually, they're all part of the same thing. What they're basically saying is that the agreement, the community pharmacy agreement, should probably concentrate on an agreement about dispensing and the fees for dispensing and what goes into dispensing, and have other mechanisms for the wholesaling component of community pharmacy and additional primary health programs and services. So what is now the CPA at the moment has dispensing, has wholesaling arrangements, and has professional services, and the professional services part of that has been growing, as we've just discussed. Instead of having that funding within 6 CPA, if you move to MBS billing, or billing through fee for service, and MBS if you're going to do like with like, then that would move it out of the community pharmacy agreement into another sphere. So we think that's important. We also have had concerns, and which have been publicly expressed many times, and actually we aren't the only people who have these concerns, about the agreement being a bilateral agreement between the Pharmacy Guild and the government. We've long argued to move away from that bilateral agreement. We think that particularly if the first recommendation at 7.1 isn't accepted, then if you continue to have a broad agreement which covers everything, then everybody who's impacted should have a seat at the table. So we think it should include consumers, and we think CHF is best placed. We are funded under the federal government to be the leading peak for healthcare consumers. We don't accept the argument that at the table the Pharmacy Guild represents pharmacies and the government represents consumers. We think government has a lot of competing priorities that it has to balance up. We think consumers need to be there explicitly. We also think the Pharmaceutical Society of Australia, as the professional body for pharmacists, should be a party to the agreement. There are a number of community pharmacies that are not members of the Guild, and they need a voice, plus consultant pharmacists as well, and they're all impacted by the 6th CPA if it stayed as a broad agreement, and so it should involve other people. So that gets me to the end of my presentation, and I'm sorry it's a bit of a short run through and it doesn't cover everything, but hopefully that will get us somewhere. One of the questions we've got is why do funding models focus on drugs, not exercise? I think the issue is that this is a pharmacy model, which this is an agreement about funding medicines predominantly, the community pharmacy agreement and the review of pharmacy remuneration and regulation. So it's about funding drugs. I think it's a good question about when do you use a drug therapy and when are there other interventions. And you know, we can look at pain management, for example, and we know that there are other ways to manage pain other than drugs. So we need more government funding and attention to alternatives. But I think we do need to get the drug part right, because for some conditions and some illnesses, drugs, medicines are the way to treat them. And so we need to prescribe them properly. So we need to get them on the PBS. So we need to fund them. We need to get people prescribing them, and they need to be dispensed properly, and people need to take them. So we need to address them. I suppose this review is currently looking at that. I noticed that somebody says that there's a problem with hospitals not following up on giving follow-on scripts, which I think is part of the discharge issue. And it does vary by state. New South Wales and the ACT give the lowest level of medication at points of discharge. They haven't come to the same agreement with the federal government as the other states and territories have about what you can be discharged with as a PBS script. So often people in New South Wales and the ACT find that they sometimes just get given a script, don't get given any medication, and just told to go to the pharmacy. Well, you know, depending on how well you are or how mobile you are or where your nearest pharmacy is, that could cause you a problem. And we need to try and address that issue. And I think that's why the recommendation about the discharge pack and what happens on moving from hospital back to community is so important, and we get medicines right, because we know that if we can get people when they leave hospital with the right medication and enough of it and clear instructions on how to use it, that they are much more likely to adhere to the medicine regimen and get the benefits of that medicine that were intended, and less likely to have an avoidable hospital readmission within a short period of time. So there's health benefits from getting that part of the equation right. And I think the question, as Dominic has certainly answered that. Somebody's asked a question about charging for generic medicines, and this is interesting. I mean, the questioner says, how and why can pharmacies charge extra when you don't want to have the generic brand? Well, technically they can't charge you more than the co-payment. So if it's a co-payment, they can't charge you more for that. There are brand premiums allowable in the system, and often people will find that it is cheaper to have a generic. But again, it goes back to that whole pricing issue about what is the dispense price and the lack of clarity about how much you're actually supposed to pay. If you go onto the PBS website, if you're interested enough and want to look up the dispense price of your medicine, you will see that it gives a price that says is the maximum the pharmacist is legally allowed to charge you. That actually isn't correct for many medicines, and the government, the Department of Health is going to change that website because it actually says you can't be charged more than the dispense price plus the allowable fees. But that's not true. You can be charged up to the copay, and whether you have a generic or not, they can still charge it. So again, we need some more clarity around that one. I think the community pharmacy agreement doesn't really cover all pharmacy types. It really only covers retail pharmacy. It doesn't cover pharmacy in hospital. It covers consultant pharmacy to the extent that it covers professional services that are consultant pharmacy, so home medication reviews, medication management reviews, extra services like that, and the new services that are being trialled for diabetes screening and things which are in-house. But it doesn't cover hospital pharmacy. Hospital pharmacists are covered by state government agreements because that's who employs them, and they work to quite a different way of getting drugs and deciding which drugs they can be help with, and they have very clearly defined roles within their hospital, and this agreement doesn't touch them. So Rebecca, are there any questions on private health?
No, I've got off lightly. Thank you so much to Joanne, who has incredibly quickly already sent me through her story of why private treatment, in her case, was far superior to public treatment. We really value that story. As Joe has said earlier, if you have other stories about why you've got private health insurance, why you don't have private health insurance, your experience of using private health insurance, the terms of the inquiry that we're addressing at the moment are really broad-ranging, and so we value any stories you've got.
There is another question on pharmacy, which I guess relates to the complementary medicines and the homeopathic medicines, and perhaps not so much the over-the-counter medicines, because they do have to have a strong evidence base. And the question's asking, how can pharmacists be forced to only offer pharmaceuticals that have a strong evidence base for their use? Well, we can't tell them what to sell in their retail business, basically. We can tell them what to do with prescription medicines, where to store them, how much, hopefully we can tell them how much to charge. We can do all of that, but we can't tell them what else to sell. We can put restrictions on how they display them. We can require them to put more evidence. I mean, many consumers actually like being able to buy complementary medicines and therapies from their pharmacy. They feel better about buying them from a pharmacist than from somewhere else, from a health food shop, from a supermarket, wherever you can buy them. I think they like to feel that they can do that. Others feel very affronted that they have to walk through the banks and banks of supplements, therapies, etc., before they get to where they put their script in, and then have to stand around looking at them while it takes 10 minutes to get your script filled, or 10-15 minutes. Then you're bombarded with this displays of these things, is what people say to us. I think you've got to remember these are in a business. We have decided in this country to not just have dispensing pharmacies. We have decided to make dispensing prescription medicines part of the model that a retail community pharmacy delivers, and it's only part of their business. And so I think in all of this, that's the decision we've made. Nobody has even suggested moving to a model where we just had dispensing pharmacies, where you just went up and that's it. All they did was do prescription medicine. So I think we need to remember that in this discussion. It's about how much information. I think if the TGA reforms on our complementary medicines get up, I think you'll see an improvement in the amount of information that's provided. You'll certainly see more close monitoring of what claims complementary medicines can make and do make. And we may even see something which tells you with a simple tick, little bottle, some claimer that shows you those complementary medicines, because there are some that have a very good evidence base for their efficacy, and you'll be able to pick between them and that will make life simpler and probably make life simpler for the pharmacist as well and the pharmacy assistant. So I think those are issues where we just have to bear in mind that we can't actually tell people exactly what to do in their business, and I think that's a tension for us. So now I think we've covered most of, there's another question.
No, we're just to say that we're going to end the formal broadcast now, but we will keep the chat box open for probably about the next half hour or so. I'll be sitting here monitoring it. The best way to get onto either of us is to email Jo for questions or comments about pharmacy. Her email is there. My email is r.randall, R-A-N-D-A-L-L, @chf.org.au. These are both active and big submissions for us. So particularly before next Monday, if you've got questions or comments, we would really love your input. I'll mute our broadcast now, but we'll keep the chat box open for about the next half hour. Thanks so much.
Thank you.